we are moving to our next presentation. Here we are privileged to hear from Professor Dr. Kunkler, who will speak on the topic update on adjuvant radiotherapy for early breast cancer, focusing on the results of PRIME2 and B2.04 MRC Supremo trials. Professor Dr. Kunkler is currently a consultant in clinical oncology at the Edinburgh Cancer Centre, University of Edinburgh.
Good morning. I'd like to thank Professor Chowdhury and the Scientific Committee for their invitation. I'm going to give an address on an update on adjuvant radiotherapy in early breast cancer. And I have no financial disclosures or conflicts of interest to declare. So there have been a number of important developments in adjuvant radiotherapy in breast cancer, more sophisticated radiotherapy treatment, reduction in dose, hypofractionation, partial breast irradiation. But I'm going to focus in the right-hand side of the panel of changing indications and the de-escalation of radiotherapy in the context of breast-conserving therapy and emerging data in intermediate risk breast cancer. And Professor Chowdhury asked me particularly to talk about the PRIME2 trial. So we're moving away from a situation of one size fits all, particularly in the context of breast-conserving surgery and breast-conserving therapy. And the PRIME2 trial, which I'll be talking about, was largely based on seminal data from Hughes and colleagues in an initial trial called the CLGB 9343 trial. So this was a trial in patients with T1, N0 breast cancer who were ER positive, 636 women, who were randomized to tamoxifen alone or tamoxifen plus whole breast irradiation. And the 5-year data showed in the lower hand panel a difference of 3% in local recurrence with a reduction from 4% to 3% with radiation treatment. And this had relatively little impact in the United States in the period after publication. And then there was the publication of the 10-year data, which I think is probably has more impact on practice, where we can see that the survival curves are separating out, the difference is larger. There was a reduction from 10% in the tamoxifen alone to 2% in the tamoxifen plus radiotherapy group. So the PRIME2 trial was in a higher risk group than the CLGB 9343 trial. So this is women 65 years or older with tumors up to and including 3 centimeters in diameter. They all had to be node negative. They had an excision margin of at least 1 millimeter. They had to be ER or PR positive and treated with adjuvant endocrine therapy. And we excluded patients who had a combination of grade 3 cancer and lymphovascular invasion. So the endpoints for the trial were ipsilateral breast tumor recurrence and secondary endpoints of regional recurrence, contralateral breast cancer, distant recurrence, disease-free survival, and overall survival. So patients were recruited between 2003 and 2009, and we recruited 1,326 patients who were randomized to whole breast irradiation, 40 to 50 gray, or to no whole breast irradiation. And the fractionation range, which is between 40 and 50 gray, in 15 to 25 fractions. So if you look at the population that were included within the trial, most patients were around about the age of 70. Most of the patients had T1 tumors over 85%. And this reflects probably a quite conservative approach from surgeons and oncologists entering patients into the trial. And you can also see that most of the patients, nearly over 90%, were grade 1 and 2, with a very small proportion of patients with grade 3 cancer. And then, again, a relatively low proportion of patients with lymphovascular invasion. We did allow patients to have preoperative endocrine therapy, but they represent a relatively small proportion of patients in the trial. And then if we look at the local control rate at 10 years, we can see the irradiated patients in red, the non-irradiated patients in blue, and in the non-irradiated patients, the 10-year actuarial rate was 9.8% compared to 0.9% in the irradiated group, with a p-value which was strongly significant. And then in terms of overall survival, there's no statistically significant difference. 81% in the irradiated group, 80.4% in the non-irradiated group. And then what impact does it have on metastasis-free survival? Well, there is no difference. 98.1% in the no irradiated group, 96.4% in the irradiated group. So in conclusion, there was a 9.8% ipsilateral breast tumor recurrence rate with the omission of postoperative radiotherapy in the PT1 to 2 tumors 3 centimeters or less, node negative, hormone receptor positive in patients 65 years or older compared to 0.9%. Data I haven't shown is that most deaths, over 90% in this population, were not due to breast cancer. And therefore, the omission of postoperative radiotherapy is a reasonable option for PT1 to 2 tumors, which are grade 1 and 2. And we've excluded the option for grade 3 on the basis of the limited number of patients in that category, as there is no evidence that it increases the risk of metastatic disease nor impacts on survival. And if we look at the impact on guidelines, in 2015, when the 5-year data was published, it allowed for patients to have a radiotherapy omitted after conservation therapy, 65 years or older with grade 1 and 2, node-negative patients, on the condition that these patients received at least 5 years of endocrine therapy. So these are the 24 guidelines from the NCCN, and you can see in the central panel the data which related to the CLGB trial in patients over the age of 70, HER2 positive, HR positive, HER2 negative T1, and then the impact of the PRIME2 trial in patients over 65, hormone receptor positive, HER2 negative, node negative with tumors equal or less than 3 centimeters. And this has been part of an initiative in the United States called Choosing Wisely, to select, to avoid treatments where the impact on outcomes may be relatively modest. So I'm now going to move to another area of treatment in terms of post-mastectomy radiotherapy. I'm going to skip a few slides here because of shortness of time. And then to move to the MRC Supremo trial, the big 2.404 MRC Supremo trial, to assess the impact of the omission of post-mastectomy radiotherapy in the 1 to 3 node positive group. And this is a highly controversial area which I'd like to discuss. So in 1997, in the same edition of the New England Journal of Medicine, two landmark trials were published. One by Mary Overgaard and colleagues in a group of patients of over 1,700 patients with node-positive tumors, or those which were T3, and a smaller trial from Joe Ragaz and colleagues in a similar group of patients. And in the left-hand panel, you can see the impact of adjuvant radiotherapy given in conjunction with cyclophosphamide, methotrexate, 5-FU, compared to CMF alone, showing a 9% improvement in 10 years survival. And then there was a separate trial from the Overgaard group in postmenopausal patients, showing a similar benefit in terms of overall survival. But there were criticisms of these trials at the time. It was noted that the local regional recurrence rates in the non-irradiated group at 10 years were 32% in the larger Overgaard trial, much larger than seen in more contemporary US studies. There was criticism of the quality of the adjuvant systemic therapy, where CMF chemotherapy was considered outdated. And there were much higher, there was much criticism too of the quality of the axillary surgery, with only a median of 7 nodes removed from the axilla. But nonetheless, post-mastectomy radiotherapy became the standard of care for T3 tumors and those with 4 or more positive nodes. But the generalizability of these data to the 1 to 3 node positive group, we would consider that the intermediate risk group, was unclear. And on the basis of the data that was presented, the National Institute of Health in the United States made the role of post-mastectomy radiotherapy in the 1 to 3 node positive group a priority for research. Nor was it clear in the node negative group with additional risk factors was what the role of post-mastectomy radiotherapy was in that setting. And we know that with additional risk factors, there's a cumulative risk of recurrence. So fast forward to 2014, with the Oxford meta-analysis of post-mastectomy radiotherapy published in The Lancet in 2014. And this showed in the top panel the 1 to 3 node positive group, showing a 16% reduction in first local regional recurrence, converts in the right-hand panel to a 7.9% reduction in breast cancer mortality. And in the lower panel, there are the equivalent figures for the 4 or more node positive group. And Philip Portmans, in his commentary on these findings, indicated that there was very little difference between the 1 to 3 node positive group and the 4 or more node positive group. And on this basis, he recommended that post-mastectomy radiotherapy should be the standard of care for all node positive patients. And that has influenced the National Institute of Clinical Excellence in the UK, who published their guidance in 2018, indicating that post-mastectomy radiotherapy should be the standard of care for all patients with axillary macrometastases. So in the Supremo trial, we considered that the key target was the chest wall. So if you look back to 1999, that was the commonest site of recurrence. About 12% of recurrences occurred on the chest wall, compared to about 4% in the axilla. So the entry criteria for Supremo were PT1, N1, T2N1, and PT3N0 invasive breast cancers. But you could also be included if you had a PT2 node-negative tumor, if there was grade 3 histology and or lymphovascular invasion. You had to have undergone a simple mastectomy with a millimeter margin and an axillary node staging procedure. If you were node positive, you had to have an axillary node clearance with at least 8 nodes removed. If you were axillary node negative, that could be on the basis of a clearance, an axillary node sample, or a sentinel node biopsy. In contrast to the Danish and Canadian trials, quality assurance was applied to all the aspects of the Supremo trial: pathology, surgery, radiotherapy, and systemic therapy. So you had to be fit for adjuvant or neoadjuvant chemotherapy, adjuvant endocrine therapy, and postoperative radiotherapy. So, for example, for patients who were receiving chemotherapy, they had to receive at least 4 cycles of an anthracycline or taxane-based regime and anti-HER2 therapy according to local practice. So the endpoints for the trial were overall survival at 10 years, and the secondary endpoints, local and regional recurrence, disease-free and metastasis-free survival that I'm presenting today. Other secondary endpoints were cause of death, acute and late morbidity, quality of life, and cost effectiveness that I'm not presenting today. So patients were recruited between 2006 and 2013, and this is the consort diagram. So 1,679 patients were randomized. In the left-hand part of the panel, the no chest wall irradiation group, and on the right-hand side, the irradiated group to the chest wall. And then taking account of patients who are not eligible or withdrew from the study, we have on the left-hand side, the no chest wall irradiation group, 799 patients, and on the right-hand panel, 808 patients. And these received adjuvant radiotherapy between 40 and 50 gray in 15 to 25 fractions. And I've showed this in an amplified group on the right-hand panel. The 95% confidence intervals between 0.20 and 0.99. But what you'll note is the number of events are very small. In the irradiated group, only 9 chest wall recurrences, and in the no chest wall irradiation group, 20 recurrences. And we do not consider these to be clinically significant, so the total reduction in risk is only less than 2%. And we do not think that is clinically significant. And then if we look at the pre-specified analysis by nodal status, there is weak evidence of an effect. And if you look at the node positive group, it appears to be statistically significant, but the event rate is very small, weak evidence for an effect. And then finally, if we look at metastasis and disease-free survival, metastasis-free survival, the Kaplan-Meier curves on the left, this is not statistically significant, hazard ratio of 1.06 with a p-value of 0.60, and on the right-hand side, the disease-free survival with a p-value of 0.70 and a hazard ratio of 0.97. So what do we conclude? So in patients with intermediate risk breast cancer, with 1 to 3 positive nodes, or node negative with other risk factors, with optimal systemic therapy, does not improve 10-year overall survival. It results in a clinically insignificant reduction of less than 2% in chest wall recurrence. It has no impact on disease-free or metastasis-free survival. And we think that these findings are consistent with incremental improvements in multidisciplinary care, better screening, better pathology, better surgical attention to margins, better systemic therapy, better radiotherapy. And that finally, adjuvant chest wall irradiation should be omitted in most patients who meet the eligibility of the study. And finally, I'd like to acknowledge for the PRIME trial, the support from the Chief Scientist's Office for Scotland, and for the Supremo trial support from the Medical Research Council. I'd like to thank the patients, the Scottish Breast Cancer Trials Group, the EORTC, the Breast International Group, the Trans-Tasman Radiation Oncology Group, the Chinese Network of Centres, Public Health Scotland, and the Usher Institute at the university who administered the trial, and the trial steering, management, and data monitoring committees, funding from the Chief Scientist from the UK MRC, the National Institute of Health Research, the EORTC and the URTC Breast Group, the Dutch Cancer Society, Cancer Australia, the trustees of the Hong Kong and Shanghai Bank, and the Breast Care Institute of Edinburgh. Thank you for your attention.